So I'm David Spigel. I'm a medical oncologist and am the Chief Scientific Officer at Sarah Cannon Research Institute in Nashville, Tennessee. So I had the privilege of presenting ADRIATIC. ADRIATIC is a phase 3 trial evaluating the role of immunotherapy when used as consolidation after chemoradiation in limited stage small cell lung cancer. Limited stage small cell lung cancer is a difficult diagnosis. We haven't made really any great strides in several decades in that treatment. The standard of care has been giving chemotherapy and radiation together, but even when patients get that, most will have cancer come back within 2 years, and relatively few will live beyond 5 years. So ADRIATIC was designed to look at the role of immunotherapy in the case of durvalumab, a PD-L1 antibody, with or without a CTLA-4 antibody called tremelimumab, when used as consolidation after chemoradiation in patients with limited stage small cell lung cancer. So this was a global randomized phase 3 double-blind placebo-controlled trial. All the patients had limited stage small cell lung cancer, good performance status, and all the patients had to have received their chemotherapy and radiation given together before they were randomized on the trial. Something called PCI, or prophylactic cranial irradiation, was optional. It was up to the treating investigator in this global trial. The chemotherapy was up to 4 cycles of etoposide and platinum chemotherapy, and the radiation could be either once daily up to 66 gray or twice daily up to 45 gray. The radiation had to begin no later than the end of the second cycle of chemotherapy. So all patients were randomized to either durvalumab at 1,500 milligrams IV monthly, a placebo, or a combination with tremelimumab. The study was designed for patients to stay on therapy until disease progressed, they had intolerable toxicity, or they had received a maximum of 2 years of treatment. The analysis I presented, the primary analysis, was of durvalumab versus placebo, and that analysis included 2 primary endpoints: overall survival and progression-free survival by blinded independent central review. There are secondary analyses planned for the durvalumab tremelimumab arm, but those data sets remain blinded and will be revealed at a future analysis. The study met its primary endpoint of overall survival. It increased survival with a hazard ratio of 0.73, a 27% reduction in the risk of death if you were on the durvalumab arm compared to placebo. The median overall survival was 55.9 months versus 33.4 months on the placebo arm, so that's a nearly 2-year, 22.5-month improvement in overall survival, a major finding for patients. The study also met its secondary planned primary endpoint. Durvalumab statistically significantly improved progression-free survival. The hazard ratio for benefit there was 0.76, or a 24% improvement in your chance of having cancer, returning, or dying from cancer. That correlated with a 7.4-month improvement in median progression-free survival. That was 16.6 months with durvalumab and 7.2 months with placebo. So the study met both of its planned primary endpoints, overall survival and progression-free survival. The regimen was well tolerated. Most of the toxicity seen actually in both arms, about 23% in each arm, was due to radiation pneumonitis. There were some additional immune-related side effects seen with durvalumab, such as pneumonitis, thyroid, and skin disorders, but nothing unexpected for durvalumab, which is already used commonly in the treatment of lung cancer, so there were no surprises there. So in summary, the ADRIATIC study hit both of its primary endpoints. Both overall survival was improved with an advance of nearly 2 years in median survival, and progression-free survival was improved with an advance of about 7.4 months. The regimen was safe, and these results will translate into durvalumab being a new standard of care. Patients with limited stage small cell lung cancer who get chemoradiotherapy should then get up to 2 years of durvalumab, a great advance for our patients. Small cell lung cancer is an aggressive cancer. Unfortunately, most patients who discover they have it discover that it's at already an advanced stage, and so for most patients it will be incurable, life-threatening. But about 1 of every 3 patients who discover they have this diagnosis will have what's called limited stage disease. And so we want to try to cure as many patients as we can who have limited stage disease. And chemoradiation therapy can be quite effective, but it's just not good enough. And so to have a 2-year, 2.5-year nearly, 2-year improvement in median overall survival is really a remarkable improvement. It's not enough. I mean, we're going to have to use this as a new kind of benchmark to build upon. But there's so much excitement with what we're learning about antibody-drug conjugates, with other immunotherapy strategies, and potentially one day having a targeted approach to small cell lung cancer, that maybe this can be a new platform for which future research can be based upon.